So now we are going to discuss sleep and EEG. Okay, so what is sleep? So definition is written here that there are certain criteria to describe it as a sleep. That means there should be lying down posture. Okay, then there should be raised threshold to sensory stimulus. Okay, then low level of motor output and unique behavioral dreaming. Now first MCQ, that dreaming occurs in rapid eye movement sleep also, as well as non-REM sleep also. But the dream which is occurring in the REM sleep is recallable dream. Recallable dream means you can remember the dream in the morning after getting up from the bed, but non-REM dream is non-recallable. Okay, non-recallable dream, you will not be able to remember. Now see, apart from this 4 feature, the other feature is it is easily reversible. Okay, so all this feature can also be seen in case of a coma patient, but the patient of coma, it is not easily reversible, but sleep is easily reversible. Okay, now to diagnose whether the person is in REM sleep or non-REM sleep, you require to study the sleep, and study of sleep is known as the polysomnography. To study the sleep, you have to record certain parameters. What are the parameters? So number 1, EOG, electrooculography, movement of the eyeball, ocular movement. Then EMG, electromyography, electrical activity from the motor units of muscles. And number 3 is EEG, that is the electroencephalography. These are the 3 main recording for polysomnography. But apart from that, what are the other recording that is also done is the SpO2, that is the oxygen saturation is also measured. ECG is also taken, and breathing functions is also assessed during this polysomnographic recording. With the help of this polysomnographic recording, you can classify whether the sleep is REM sleep or non-REM sleep. Now, first of all, we have to discuss what is this EEG. So, what is electroencephalography, right? So, in human, the first recording of EEG is done by Hans Berger. He first time record the human EEG, but he record only the alpha wave. That's why alpha wave is also known as the Berger's wave. Okay, Berger's wave. Now please note down what is EEG. Try to understand. Now we know the cerebral cortex has 6 layers. Suppose this is 1, 2. So I'll draw from here. So suppose these are the different layer 1, 2, 3, 4. This is 5 and layer number 6. At the layer number 5, we know there are pyramidal cell, giant pyramidal cells are there here. The dendrites of this pyramidal cell extend even up to the superficial part of the cerebral cortex like this. Okay, so these are the dendrites extending from the pyramidal neuron. Okay, now please note down that action potential of this pyramidal neuron is generated at the level of this initial segment, because that is the portion where the action potential is generated. So action potential initiated at the initial segment. But in EEG, the electrodes are placed on the surface of the scalp. So obviously, if I place the electrode here over the surface of the scalp, it cannot record the electrical activity which is occurring in the deeper part of the cerebral cortex. That means EEG is not the action potential of the brain neuron. Please note down first. Although we blandly say that EEG is the electrical activity of the brain, but it is not action potential. So what is that? We know these dendrites at the site where multiple synapse formation occurs. So suppose here this is an excitatory synapse, and there will be obviously inhibitory synapse also. So suppose this is an inhibitory synapse. So these are the inhibitory synapse, excitatory synapse. Now whenever excitatory synapse is stimulated, there will be potential generation at the level of these dendrites or postsynaptic neuron, we can say. So this postsynaptic potential which is generated by the excitatory neuron is nothing but EPSP. So basically in this neuron, EPSP is nothing but a dendritic potential occurring at the level of dendrites. Similarly, the inhibitory neuron produce potential, that is the IPSP, inhibitory postsynaptic potential. Again, it's a kind of dendritic potential. So there will be millions of billions of synapses in the cortical region of the brain. All will produce some kind of positive voltage or negative voltage, and because of this, what will happen? There will be flow of current like this, flow of current from one part to other part. Because of this flow of this current, there will be shifting electrical dipole, and this shifting electrical dipole will give rise to various waves in EEG, right? So basically, if I place a electrode on the surface of the scalp like this, I am going to get certain electrical activity, EEG. Which electrical activity? All the EPSP, all the IPSP which are occurring on the dendrites. That means EEG is nothing but summated voltage of all the EPSP or all the IPSP which are occurring simultaneously. So the EPSP, IPSP, what are they? They are nothing but dendritic potential. So that's why it is written that EEG is nothing but summated version of all the dendritic potential or EPSP or IPSP. So they're the local potential basically. They are not the action potential, right? Now rather than placing the electrode on the surface of the scalp, which is generally done in case of EEG, if you place the electrode directly over the surface of the cortex here, okay, just above the pia mater, okay, then the same recording is known as electrocorticogram. This is known as electrocorticogram, okay, just above the cortical surface of the brain, above the pia mater, okay. So this is electroencephalography and electrocorticography. Now EEG produce spontaneously, so that is spontaneous activity of the brain. On the other hand, if I stimulate a particular sensory neuron in your any part of the body, suppose I am giving a pain stimulation here, so we know this neuron will carry this sensation up to the level of the somatosensory cortex, and somatosensory cortex will be stimulated. Can I record this voltage? Answer is yes. So suppose this is the surface scalp, okay, here I have placed one electrode, and the electrode is directly over the somatosensory area number 1, okay. So note down, electrode is placed directly over the somatosensory area, and now from the periphery you are stimulating the neuron, and neuron is ultimately reaching at the level of somatosensory area. So what kind of stimulation? Somatosensory receptor is stimulated. So again it will produce a voltage change at the level of this electrode, but this is known as evoked potential. So please remember, EEG is electrical activity spontaneously generated. Evoked potential means you have to stimulate the particular brain area. If you stimulate the sensory neuron, so your electrodes should be placed directly over the somatosensory area. If you stimulate the retina, so obviously the electrodes should be over the occipital lobe like that. So that if you stimulate the retina, that is known as a visual evoked potential. If you stimulate the auditory neuron, then auditory evoked potential. But here I have stimulated the somatosensory receptor. That's why this kind of evoked potential is known as somatosensory evoked potential. So what is the difference? Difference is that stimulus is required here. You have to stimulate. Second, the voltage which is produced here is few microvolt only. EEG is also in microvolt, but tens of microvolt, maybe 100, maybe 200. But here the voltage is only few microvolt. Please remember. So stimulus is required and voltage is very less. Okay. Now whenever you give a stimulus at the level of peripheral sensory receptor, you will get a voltage recording at an interval of 5 to 12 millisecond. So suppose I am recording this voltage change. So I have given the stimulation here. So this is the stimulus point. After a latency of 5 to 12 millisecond, I am going to get a positive followed by a negative recording. This positive followed by negative recording is nothing but somatosensory evoked potential, right? So this latency is important here, and this positive negative combination of wave is also important, right? Now what is the utility of this somatosensory evoked potential? Generally this is done for intraoperative neuromonitoring. This is generally done for intraoperative neuromonitoring. Okay, so you are monitoring the patient whether you are compressing some nerve or not. So this kind of evoked potential recording is done. So this is the difference between EEG and evoked potential. Now move on to the next, that is what are the waves that is seen in case of EEG. So remember like this: beta, alpha, theta and delta, right? So B, A, T, D. So B, A, T, dance like this. So whenever you move from beta towards delta, what is happening? Your frequency decreases, but your voltage, what is voltage? That is the amplitude increases. Okay, so whenever you are moving from beta towards delta, frequency decreases and voltage or amplitude increases. Always remember, frequency is the thing which depends on the activity of the brain. More the active brain, more will be the frequency. And voltage basically depends on the synchronicity of different waves. Suppose one is coming like this, one voltage, another voltage is coming like this. This is asynchronous. But if one voltage is coming like this, another voltage is coming like this, so synchronous. So the net voltage will be more, amplitude will be more. So frequency is proportionate to brain activity. Please remember, more the brain active, more will be the frequency. So that's why between these four waves, beta wave has maximum frequency. So what is the frequency? Okay, so note down from this table. Okay, note down from this table. But before that, how to remember? Remember like this. Suppose you are reading physiology, so boring one. Okay, so suppose you have taken a promise that today you are going to finish up the memory chapter. So the difficult one. So initially you are concentrating hugely that I have to understand every part of the memory. So when your brain is active, you are focusing on something, you are concentrating on something, your eyes are open, you are going to get the B wave, beta wave. Okay, so here person is awake, alert, eye open. So please remember, alert is much more important than eye opening. Why? Suppose you are in an exam hall, okay, and you have not revised physiology, which I told that at least revise 3, you have not done that. So what will you do in exam hall? You will try to remember like this. So your eyes are closed, but you are trying to concentrating on something. Okay, so your brain is active. This will produce again your beta wave, although your eyes are closed. So your brain has to be alert. You are focusing on something. Okay, so this is beta wave. Now, whenever you are reading, but you are not understanding memory. So what will you do? You will close your eyes and your mind will start wondering that forget about physio, I'll do something after this NEET exam, I'll go for movie, I'll do that, I'll see Netflix and something like that. So whenever your mind is wandering here and there, your mind is relaxed, forget about study. Your mind is relaxing. Whether your eyes are closed or not, you are going to get which rhythm? Alpha wave. Okay, so beta followed by alpha. Okay, awake person, quiet person, relaxed person, eye closed. Then after some time, your mind is wandering. Now you are feeling drowsy, you are entering into a light sleep mode. What wave you are going to get? You are going to get the theta wave. So this is light sleep, theta wave. And then after some time, you are not able to hold your posture on chair. You are entering into the deep sleep like that, and you are going to get this delta wave. So this is deep sleep. So try to remember like this. So now look at this table to understand what are the different frequency of this wave. Okay, so beta wave, BAT, I told you like this, BAT dance. So beta wave frequency 14 to 13 hertz, 30 hertz. Alpha wave 8 to 13, theta 5 to 7, delta 2 to 4. So whenever you are moving from beta to delta, your frequency is going down. Now look at the voltage. You may not remember each and every voltage, but look at here, this is only 20 microvolt. But whenever you are going towards the delta, it is said that delta wave has a voltage which is 2 to 4 times that any of the EEG wave, means it can around 200 microvolt like that. Okay, so this is 20 and it is around 200 microvolt. Now beta wave is more prominent in frontoparietal region of the brain. So beta wave is more prominent on the parietal frontal region of the brain. Alpha wave is more prominent on occipital region of the brain, more intense, more prominent. It is said that alpha wave originates from the thalamocortical projection of brain, means from thalamus towards the cortex there is diffuse projection going on. These are the neuron which give rise to alpha wave. So write down here that this is thalamocortical projection, right? Apart from that, reticular activating system is also responsible for this alpha wave. Now followed by theta wave. See here what is written. Theta wave is more prominent in the parietal temporal region in case of children. It is also seen in different emotional stress in adult, particularly frustration, disappointment. So if you don't read carefully, your NEET result will not be very good. You will be frustrated, you will be emotionally stressed, and I am going to get theta wave from your brain, right? And after that, the delta wave, it is seen in deep sleep in case of infant and serious organic brain diseases. So these are the different waves in the EEG, right? Now see here the EEG recording. Okay, we'll see few more recording also. So first you look at the above recording. So here this is alpha wave as it is written. Voltage is more. Okay, so alpha wave when they are produced, alpha wave produced when you are relaxing, your eyes are closed and your mind is wandering here and there. Now if I give any kind of sensory stimulus like that, okay, so suppose your mind is wandering, you have closed your eye, I'm giving, hey, what are you doing? So this is a kind of sensory stimulation. What will you do? You'll just open up your eyes. What the side is saying? What's that? So whenever your eyes are open, you are concentrating, try to concentrate on what is happening. Your alpha wave will be converted into beta wave, high frequency active wave. Okay, and whenever the frequency is high, particularly note the voltage decrement. Okay, here particularly note the decrease in voltage in y-axis, and x-axis is the time. So voltage decreases and frequency so high that you are not able to count itself. How many peaks are there? You are not able to count. That kind of wave is beta wave. So in presence of eye open, in presence of sensory stimulus or sensory attention, what is happening? Alpha wave is converted into beta wave. This is known as alpha block phenomena. This is known as alpha block phenomena. Simple can be given as an image based MCQ. Okay. Now on the other hand, come to this second diagram, right? Second diagram. So I told you frequency is proportionate to brain activity. Okay. So suppose here the time scale is given here 1 second. Within this 1 second, you are counting the peak here. Okay. So suppose only 3 peak. So 3 Hz. What is the wave? So this is generally delta. Delta wave is seen in case of surgical anesthesia and deep sleep, right? Now whenever there are certain kind of psychomotor activity, see here you are getting more frequency wave here. This is nothing but theta wave. Okay, then you are in a relaxed state. Okay, relaxed state, your frequency is more higher. Okay, now the wave which you are getting here is nothing but alpha wave. Okay, after that you are giving attention to something. So what is happening? The frequency is more higher. Okay, and this is nothing but which wave? Beta wave. And look at the pathological state, that is the tonic-clonic seizure. Okay, whenever this is occurring, the frequency is very high. Okay, so this is the typical thing which is showing that more the activity in the brain, more will be the frequency, right? So please try to understand this diagram, important. Now apart from this alpha, beta, delta or theta, there is something called gamma wave, and this is the highest frequency wave which is seen in the EEG with a frequency of 30 to 80 Hz. So more frequency means the brain has to be more attending, right? Okay, so the condition which produces or give rises to gamma wave in EEG is known as the binding in neuron. What do you mean by that? Means multiple areas of the brain is simultaneously activated hugely due to certain condition. That is known as a binding problem in neuron or binding in neuron, and that will give rise to gamma wave. What is the condition? Written here. During problem solving, you are try to solve complicated problem, or meditation, obviously not your meditation, that is a yogic meditation, working memory formation, learning, attention and mental sharpness will produce gamma wave in the EEG, right? Now, after the discussion of different waves, now we are going to discuss different types of sleep, right? So all of us know that sleep is mainly of rapid eye movement type of sleep, REM, rapid eye movement type of sleep, and second one is the non-REM sleep, right? Now non-REM sleep is also divided into like this: stage 1, stage 2, 3 and stage 4. Now recently there is a newer classification where this name of stage 1, stage 2 has been changes. The stage 1 is now known as N1 stage, stage 2 is N2, and stage 3 and 4 this is N3, and this REM sleep is known as R stage. Okay, so this is the new naming. Okay, N1, N2, N3 and R stage, right? So whenever the person is entering into any kind of sleep, what will happen? He will first enter into the N1 stage. So whenever you are entering, start, so this is the starting point of sleep. You are entering into N1 stage or stage 1. Then N2 will be there, then N3 followed by REM, and then again N1. So this is known as a sleep cycle, but please note down, although we are saying that N1 to N2, N3 then REM, the cycle will always move from N1 to N2, N3, REM for the first cycle only. After that, it may or may not follow each stage. Means, after the first cycle, you may directly enter into the N2 bypassing the N1. You may directly enter into the N3 bypassing the N2 also. That means first cycle is maintaining all the stage, but after the first cycle, it's become irregular. Now the total cycle duration is how much? So N1, N2, N3, REM. What is the total duration of a single cycle? See, whenever you are entering into the first cycle duration is 70 to 100 minutes. But later cycle has a duration of 90 to 120 minutes. On an average, I will remember 90 minutes. So if I ask you what is the average duration of a sleep cycle means consists of N1, N2, N3, REM, 90 minutes. So obviously, if you are sleeping for 6 to 8 hours, basically you are completing around 6 to 7 cycle or maybe 5 to 8 cycle, okay, depending on your sleep time, right? So what is the percentage of different stages of sleep? Now look at here, okay. Non-REM sleep, it is a maximum. You spend maximum 75 to 80% time in non-REM sleep, okay, and REM sleep is only 20 to 25% of total time period of sleep. Non-REM sleep is also known as the slow wave sleep, and REM sleep is also known as paradoxical sleep. We will tell you why. Okay. Now the non-REM sleep, N1 is only 5% of the total time, N2 is the 55% and N3 is 15%. Means maximum time is spent as N2 sleep. Okay. What is the identifying feature of N1? Stage 1 of non-REM sleep. Alpha to theta. If I have to mark only one, I'll go for theta. Why? Because alpha means the subject is still awake. Mind is wandering. Okay. But theta indicate the person has already entered into the light sleep. So theta is the single best answer. Then N2, it is determined by sleep spindle and K complex detection in EEG recording. What is that? We are coming there. And N3 is detected by identifying the delta waves. Okay, so now look at here. This we have already discussed. N1, N2, N3 and REM. What is the duration? 90 minutes. Okay, now here look at the different stages, how the person is moving from one to other. So see, this is REM, then N1, N2, N3. So whenever the person is entering, he is entering here, N1, then he is spending some time at N2, then he is spending some time in deep sleep stage. Then step by step he is moving on to N2 again, then N1 again, and then he is moving for REM sleep. Okay, so starting from here up to this completion of REM, this is nothing but a single sleep cycle. So if I ask you, during this non-REM sleep, which kind of EEG wave you have seen? You have seen theta and delta. Theta and delta means what is the frequency? They are the slow frequency wave in the EEG, and that's why the sleep is known as the slow wave sleep or deep sleep in non-REM. But REM sleep, look at REM sleep, the particular wave which is seen during the REM sleep is the beta-like wave. Okay, we'll come to that point. Okay, this REM sleep indicate that's a kind of paradoxical sleep. Why? Because you are getting beta-like wave. Tell me why, when you will get beta wave? Beta means when the person is awake and when the person is concentrating on something. Although you know, REM sleep, the person is entering, the person is already in the sleep stage, but you are getting as if the person is awake. They are contradicting. Okay, your recording of muscle, recording of eyeball is saying the person is in the sleep stage, but your EEG recording is saying the person is as if the person is awake. That's why it is known as paradoxical sleep. Okay, now also note down, whenever you are moving from early stage of sleep to the late stage of sleep, okay, towards the morning, what you are getting, your REM sleep duration increases. Okay, so the first cycle REM sleep percentage is very less. Towards morning, your REM sleep duration increases, right? Okay, so what is sleep spindle and K complex? That is the identifying feature of the non-REM stage 2. So sleep spindle, as you can see here, this is a spindle shaped wave seen in stage 2. Okay, and frequency is 12 to 14 Hz. And what is K complex? This is the very sharp biphasic high voltage wave. See here, sharp high voltage biphasic wave, that is K complex. Both are seen in case of stage 2. But note down, this sleep spindle is also known as sigma wave. It indicates the onset of stage 2, very important, and it's a definite feature of stage 2, and it first appeared as 6 to 8 weeks of infancy, right? So please note down this point. Now look at this diagram and tell me what this arrow indicate. So see, this is a sharp high voltage biphasic wave. What is that? That is the K complex. So K complex in which stage? Stage 2. Whenever you are moving into stage 4, deep sleep, you are giving slow wave. So this is 5-second period. If you count the wave 1, 2, 3, 4, maximum 5-6 Hz you are getting within 5 seconds. So obviously this is nothing but delta. Okay, that indicate deep sleep stage or stage 4. Okay, now what are the physiological changes during this non-REM and REM sleep? First, coming to the non-REM sleep. First, remember, non-REM means that is the resting stage of sleep. What is the requirement of sleep? Your brain is getting rest. Okay, so this rest is mainly seen during non-REM. So what will happen? Sympathetic system will be down and parasympathetic system will be up. And if that is occurring, what will happen? Everything you can answer, that metabolic rate will be decreased, brain and body temperature will be decreased, and muscle tone will be obviously decreased, but it will remain intact. It will not lost. This intact means tone will not last, it will remain intact, but obviously lesser than that of the awake stage. On the other hand, look at the REM sleep. I told you already that active dreaming occurred, vivid, active, recallable dreaming occurred during this REM sleep. Apart from that, we know rapid eye movement will be detected. Muscle tone is completely lost. Muscle atonia, muscle paralysis like condition. That's why it is very, very difficult to wake up the person from the REM sleep to direct awake stage. You can wake up the person from any stage of the non-REM sleep. This is easier, but because during the REM sleep, the muscle tone is severely paralyzed, it is very difficult to get awake from REM sleep stage. Okay, and see, already we have explained beta-like wave is seen during EEG. That's why this is known as a paradoxical sleep. Now note down the next point, important. Pontogeniculo-occipital spike. What is that? The cholinergic neuron at the level of pons increases their discharge rate during REM sleep, and this discharge or this activity of the cholinergic neuron from pons go to the level of lateral geniculate body. From there it moves to the occipital region of the brain. That's why the wave is known as the pontogeniculo-occipital wave, which is typically seen during REM sleep. What is the role of this pontogeniculo-occipital wave? Still not known. But in animal study, it has been proved that this wave is responsible for consolidation of memory. So it may be that this is same for human being also, but we still don't know. And the next point is increased sympathetic outflow. I told you already that non-REM sleep is the resting stage, but this is not the resting stage of sleep. See here, your sympathetic discharge increases. So what will happen? Metabolism, everything will be higher. That's why we say that brain is not getting rest during the REM sleep. It is getting rest during the non-REM sleep, right? Next, see this. Now look at this images. So here I have given you 3 recording: EOG, EMG and EEG. So first, awake state. Okay, right? So what you are getting? You are getting EEG recording. See, this is a kind of beta wave, right? And EMG activity is very, very high. That's why you are getting this kind of wave, right? And obviously your eye movement will continue. Now whenever you are entering into the stage 1, see, your EMG activity has been decreased, but still it is there. That's why you are getting some kind of noise or some kind of activity in this EEG. That means muscle tone is still intact, but it is lesser than the awake person. Second, obviously you are in the sleep stage, so your eye movement decreases. And what is happening in this EEG? EEG, you are getting alpha to theta conversion. So here alpha to theta conversion. Now when you are entering into the REM sleep stage, what is the most prominent finding? That is muscle atonia. Look at the muscle tone here. Muscle activity is completely silent. That means muscles is almost paralyzed. Along with that, you are getting increased activity of the eye. And see the wave. You are getting high frequency wave, which is similar to beta like wave, and this is typical of REM sleep, right? Now in the next slide, certain point has been written about the changes of sleep in different periods of life. What is that? Total sleep time decreases with age. Okay, all stages of sleep are reversible except REM to awake stage, I discussed already. Then REM sleep percentage is more in case of premature infant. 80% of the total sleep period is the REM sleep. Okay, and in case of full term neonate, it is 50%. Whenever the ages increases, the REM sleep percentage decreases like this. After 65 years of age, REM sleep is only 15% of the total sleep period, right? Now we are coming to the mechanism of sleep. Okay, what is the mechanism? So the main center which regulates the sleep we already discussed, that is the hypothalamus. Okay, hypothalamus. So one is wake promoting area, that is at the level of posterior hypothalamus, and one is sleep promoting area, that is the anterior hypothalamus. So this anterior hypothalamus is sleep promoting area and this posterior hypothalamus is wake promoting area. Already we have discussed this. Which nucleus of anterior hypothalamus? VLPO, ventrolateral preoptic area, VLPO. Okay, and it produces which neurotransmitter? GABA. That's why it's a sleep promoting area. And which nucleus in the posterior hypothalamus? Tuberomammillary nucleus, and it's wake promoting area. Why? Because it produces which neurotransmitter? Histamine. Okay, so first we are starting here. So whenever your wake promoting area is active, that is the posterior hypothalamus, it sends signal to two nucleus. One is the Raphe nucleus and one is the locus coeruleus. Okay, these two nucleus, locus coeruleus and Raphe nucleus, they are part of the reticular activating system or ascending reticular system, whatever, reticular nucleus. Okay, so this Raphe nucleus, they produces neurotransmitter serotonin, and this locus coeruleus, they produces neurotransmitter norepinephrine. These two neurotransmitter stimulate the thalamic nucleus, intrathalamic nucleus and reticular nucleus of thalamus, and from thalamus diffuse projection goes to the level of all part of the cortex, and because of this diffuse projection, what will happen? The cerebral cortex will remain active and the person will remain awake. So how the posterior hypothalamus is keeping you awake? By secreting this neurotransmitter at the level of reticular activating system. Okay, reticular activating nucleus, serotonin and norepinephrine. Okay, they are stimulating your cerebral cortex. Now suppose your cerebral cortex is awake for long duration, you are studying for your AIMS entrance examination for long duration. What will happen? Your brain neurons are very active. When the neurons are very active for long duration, it produces increased amount of metabolites in the brain. So there will be metabolites accumulation in your brain. Among various metabolites, the main metabolites which is responsible for onset of sleep is adenosine. Note down here, adenosine. So because of increased brain activity, adenosine level increases to a very significant level. This adenosine from basal forebrain stimulate the anterior hypothalamus, which releases GABA, and because of this GABA release, what will happen? The wake promoting area of hypothalamus will be inhibited and sleep promotion will be there. And whenever you are getting sleep for 6 to 8 hours, again your metabolite level in the brain will decrease, again your wake promoting area will be active and the person will get awake again. This theory of sleep is known as metabolite theory of sleep. Now apart from this metabolite theory, Genong has given another theory, that is the neurotransmitter theory. Okay, neurotransmitter theory. In this theory, it is said that this waking and this REM sleep, they are extreme of one another. Waking and REM sleep. When the person will be remain awake, when the norepinephrine is very high, or if the serotonin is very high. Just now we have discussed from two nucleus, we have discussed already. Simultaneously, the acetylcholine must be low. So please remember, if your norepinephrine and serotonin is high and if your acetylcholine is low, then you will remain in awake stage. Whenever neurotransmitter condition is just opposite to this, means norepinephrine is less, serotonin is also less, but acetylcholine is very high, the person will enter into the REM sleep. So where from this neurotransmitter are coming? Reticular activity. activating system. Question: who will signal that whether the person will remain awake or the person will go for sleep? The peptides orexin. I told you already that it is produced from lateral hypothalamus. This will give the switch that whether the person will remain awake or the person will go for sleep. So switching between these two stages is done by this. Now, if your GABA is less and histamine is high, we know where from this neurotransmitter is produced. They are from hypothalamic nucleus. Then the person will again remain awake. Conversely, when the GABA is high and histamine is low, the person will enter into the non-REM sleep stage. It is said that when the person is entering into the non-REM stage, what is the condition of this neurotransmitter? There is a perfect balance between this neurotransmitter during the non-REM stage. Means the norepinephrine is still there, serotonin is also there, acetylcholine is also there, but there is a balance between this neurotransmitter. Along with that, your GABA is high and histamine is low. You will enter into the non-REM sleep stage. So this is known as the neurotransmitter model of the sleep. Okay, so combination of all these, if you want to remember like this, that the person is awake mean norepinephrine is high, serotonin is high and acetylcholine is low. Okay, reduced GABA and increased histamine. This is the condition in awake stage. REM sleep stage, acetylcholine must has to be high, means this reverse of the above, and non-REM sleep stage, increased GABA and reduced histamine is required for that. Now coming to certain sleep disorder. Okay, non-REM sleep disorder and REM sleep disorder. Non-REM sleep disorder, you know this disorder: sleepwalking, sleep talking, bruxism, nocturnal enuresis and night terror. All occurs during non-REM sleep. Now I have written at particular which stage these are occurring. Okay, here it is given: sleepwalking means deep sleep, stage 3 and 4. Sleep talking means superficial, stage 1 and stage 2. Bruxism also stage 2 and stage 1. Okay, and nocturnal enuresis, bedwetting, all stage of non-REM and REM sleep except stage 1. And night terror, transition from stage 3 to stage 4. On the other hand, what are the disorder of this REM sleep? One is narcolepsy and one is nightmare. Okay, now what is the difference between this night terror and nightmare? See, nightmare, they are occurring in which stage? REM sleep. So that's a kind of recallable dream, and non-REM is the night terror, that is non-recallable. See here, the night terror means there will be huge amount of increased sympathetic activity, like sweating will be there, there will be autonomic arousal, there will be tachycardia, large dilated pupil, and the children will not be able to recall the dream. Okay, but nightmare, it's a vivid, frightening kind of dream, okay, which leads to fear, terror and anxiety, and the person is able to describe the detail of the dream content. That is the nightmares. So this is all about the sleep.